next talk. We'll try and have more discussions. I know it's a very, very interesting topic. Nishida is always a hot topic of discussion, and it's been used in a variety of conditions. But now we'll be having the next talk by Dr. Seyhan Ozkan. She is a professor and chief of pediatric ophthalmology at the Adnan Menderes University Medical School in Turkey. She's also the president of the Strabismological Society of Turkey, Turkish Ophthalmological Association, and is the past president of the International Strabismological Association. She is an outstanding speaker and has a large number of excellent publications in most areas of strabismus, but really has her greatest expertise in tackling managing complicated strabismus. So again, another difficult topic Dr. Seyhan is going to talk on: when and how to use botulinum toxin in reoperations. Welcome, Dr. Seyhan.
Thank you, Dr. Saxena, for this very kind introduction. And just a very short correction, I was the past president of the strabismus branch of Turkish Ophthalmological Society. So do you see my presentation in full screen mode?
Yes. We can see it.
Okay, thank you. So, dear moderator, dear colleagues, it's my distinct pleasure and honor to participate in this AEOS meeting and in the APOS symposium, and I'd like to thank the organizers for this kind invitation. I have no potential conflict of interest to disclose. So, in reoperations, botulinum toxin may be used either instead of reoperations as an adjunct to surgery to increase the success of surgery, or as a rescue agent for reoperation failures. So the basic function of botulinum toxin is known that by alteration of mechanical contractile forces. However, in acute phase, additionally, botulinum toxin functions through soft tissue healing in desired position and somehow with a similar effect with traction sutures. In chronic phase, the additional effect is mostly through the central adaptive mechanism. So when we look at the indication categories, when we look at the previous literature reports, there are two randomized controlled studies in infantile and acquired esotropia, and the authors compared surgery and botulinum toxin in reoperations, and they found that the effect was similar. However, in toxin group, the effect was more when the injection is done during the first 3 to 6 months of postoperatively. And Alan Scott demonstrated that the results are almost similar with primary toxin injections. And in consecutive ESO deviation, the success rate is around 70%. However, the success rate is higher in those who had fusion potential, and this was reported by the Moorfields group. So from now on, I will go on with some demonstrative case examples. This child has a cerebral palsy and Parino syndrome, and she underwent 4 horizontal recti supraplacement in combination with a small recessed resect in the right eye because of this moderate esotropia. And postoperatively, she was found to have a large consecutive exodeviation with limitation of adduction. And I thought that the medial rectus muscle was disinserted. So she was operated again. And on forced action test, adduction was +4 positive. There was nothing wrong in the medial rectus area. So we recessed the resected lateral rectus muscle. However, postoperatively, there was only moderate improvement, and she still had this large exotropia with limitation of adduction. So apparently, this child has a problem of abnormal muscle contractility, which is similar to the skeletal muscles in cerebral palsy cases. So we've injected toxin into the right lateral rectus muscle, and this is her appearance post-toxin 3rd month, and she remains stable in that position. So there are some specific problems that may require toxin injection in reoperation patients. And these are excess advancement of stiff muscles, excess scar tissue, excess re-resection, and adjustable sutures may not always solve the problems. This lady has a right consecutive exotropia with slipped medial rectus muscle in combination with stretched scar. So this stretched scar and the empty muscle capsule was excised with some advancement, and the lateral rectus muscle was recessed on adjustables. She was fine on adjustment. However, she came back with this consecutive esotropia on the postoperative 2nd week. So at this stage, we have injected toxin into the medial rectus muscle, and this is her appearance post-toxin first week, and 9 months afterwards, the result was stable and she was orthophoric. So the toxin balanced the contractile force in the early post-op period. And this lady was referred for a lost muscle. The lateral rectus muscle was lost. And at presentation, it was post-op 7th day. There was very significant inflammatory reaction, and there was orbital fat tissue under the conjunctiva. So adherence syndrome was also the problem. So at this stage, I didn't want to operate her, but we wanted to keep this eye in primary position while waiting. So toxin was injected into the medial rectus muscle. And 1 week afterwards, she was orthophoric with limited adduction and abduction. And 6 weeks later, she was operated, and the lateral rectus muscle was found within the orbital fat tissue. It was reattached with some recession, and the final result was orthophoria with some limitation of both adduction and abduction because of the fat adherence problem. So what is the mechanism here? So we know that when there's a lost muscle, the unopposed contracture of the antagonist may develop as early as 2 weeks, as demonstrated by Anthony Murray. And the eye moves towards the other direction. And if there is additional adherence syndrome problem, and this inflammatory adipose tissue attaches the globe at this position, causing a very significant limitation of motility. So if toxin is injected during the acute stage before these attachments developed, and the eye is kept in primary position, then all these attachments develop when the eye is in primary position, so that will cause a less limitation of ocular motility and enables an easier access to the lost muscle area. So we know that recurrent deviations are also a problem. This gentleman was also referred for a lost muscle. The medial rectus muscle was lost and the muscle was found and reattached. However, he had this residual exotropia after 2 operations. So toxin was injected into the lateral rectus muscle, and this is post-toxin 2nd month. And despite he had a secondary deviation, he was lucky enough to have a stable result. However, we know that some patients may have recurrent deviations despite they have multiple surgeries. So from Moorfield's group, a large series was reported, and it was found that these patients have no binocular function. They require regular injections, but there's no upper limit for re-injection. And there's a tendency of the interval of the injections to increase and the angle of deviation to decrease in time. So botulinum toxin may be used to rescue over and under corrections in paralytic cases as well. And this lady has a superior rectus contracture in combination with superior oblique palsy. So she underwent superior rectus recession on adjustables in combination with this inferior oblique disinsertion. She was fine after adjustment, but she came back 1 month after surgery with this significant overcorrection with left hypotropia. So at this stage, we have injected toxin into her left inferior rectus muscle, and this is post-toxin 1st week. And you see the underaction in the inferior rectus muscle, and this is post-toxin 4 years. Nothing else was done for this patient, so toxin rebalanced the overcorrection. And that lady has 2 previous operations, and she had third nerve palsy in the left eye. And she also had intractable diplopia, which did not respond to prism therapy. So in this lady, you can see the limitation of adduction here, and toxin was injected into the left lateral rectus muscle. And after toxin injection, you see how the adduction improved, and she started to fuse, and it was possible to obtain a permanent result as she started to fuse afterwards. And this young lady had 2 previous operations, and she had third nerve palsy. And in this patient, we aim to obtain an overcorrection in the early post-op period. So the right lateral rectus was recessed and the left lateral rectus muscle was re-recessed in combination with toxin injection, and the medial rectus muscle was re-resected as much as we can. And this is post-op overcorrection. The effect is similar with traction sutures. And here you see below the post-op 8 months that the result was stable. And this patient had a joint syndrome problem, and he had 2 previous operations, and he had this overcorrection, and the presumed surgery was a medial rectus recession and vertical rectus transposition. And he had this large abnormal head posture, and he was highly bothered with that, with large exotropia in primary position. So in this gentleman, we have performed a toxin injection into the right lateral rectus muscle. And despite this was a chronic case, a rebalance of the contractile forces was possible. And here below you see the post-toxin 6 months, and it's been now 1 year afterwards, and he's still stable. So there are some specific challenges in the use of botulinum toxin in patients with reoperations. First one is excessively recessed antagonist muscle cannot take up the slack. So this is a problem for a permanent effect. And injection of recessed muscles require deep injection. Injection through scar tissue is challenging. There is a risk of globe perforation. And there's a difficulty to reach the target tissue. So EMG controlled injections should be performed. So the take-home messages are: toxin is useful in reoperations, either as primary treatment or as an adjunct to surgery. And timing of botulinum toxin injection is a critical decision for a better permanent result. And consider toxin for those with no other chance for reoperations as a maintenance therapy for a better quality of life for those who had multiple previous surgeries. I'd like to thank you for your attention, and I'd like to remind you the next ISA meeting, which is going to be held in Cancun, Mexico. And namaste. Thank you.